The hospital has been notified that Joint Commission together with CMS will be resuming survey activity, and everything points to a joint visit at Jackson as early as this month. So we are definitely not ready. Readiness rounding done by other management and executive personnel have consistently revealed opportunities for improvement, which is actually just another way of saying Joint Commission citations. So what does that mean to us? Well, if the hospital receives citations that are nursing related, it means that we will all be entered into corrective action planning, which is no fun. And I guess worst case scenario is that we would lose our accreditation and our ability to take care of Medicare patients, and that would be financial disaster for the hospital. Needless to say, that would be pretty horrible for everybody and a very big deal for the hospital and the community. So this meeting is really to try to sum up everything you need to know for the survey. So please stay with me for a few minutes while we go over some things that you will need to know to be survey ready. Let's start with survey etiquette, so tips to survive the survey. Okay, tip number 1, be nice, be friendly, but ensure that you sound professional. If asked to participate, please insist that you give SBAR handoff first. Of course, we'll assist with coverage. Tip number 2, pay attention to the question and ask for clarification if necessary. Never, ever, ever guess or say something that you're not sure of. It's much better strategy to say that you have resources and would like to use them, so it's okay to check with the charge nurse or look up something in a policy. Do make sure that you know where to find the Lippincott and the JHS policy manuals on the net portal, as you may need to demonstrate this skill. Tip number 3, answer the question to the best of your ability, but stay on topic. Do not volunteer extra information. It's very dangerous when we start going down rabbit holes. Another thing that we need to know is to know the mission, vision, and values of the JHS. Mission: to build the health of the community by providing a single high standard of quality care for the residents of Miami-Dade County. Too many words, right? So just remember, mission is to deliver a single standard of care. Vision: our strategic vision is to be a nationally and internationally recognized world-class academic medical system and to be the provider of choice for quality care. Again, very long, so remember, recognize for world-class healthcare and to be the provider of choice. Finally, values. So Jackson is committed to providing the best care with care for everyone by demonstrating compassion, accountability, respect, and expertise. Keeping it simple, if anybody asks about values, you would remember that we use the CARE values: compassion, accountability, respect, and expertise. Okay, the next thing is to review national patient safety goals. So what are national patient safety goals? They were implemented back in 2003 by the Joint Commission, and they were really to help organizations address specific areas of concern in regards to patient safety. Not only will the surveyors expect that you are able to articulate the national patient safety goals, but they'll actually be observing the staff to see if we are compliant. So they'll mark you as either compliant or not compliant, and in many cases, even one score of non-compliant will result in an RFI, which is a requirement for improvement, not a good thing. Goal number 1, identify patients correctly. So that sounds simple, but not so much. So using 2 patient identifiers all the time, we're going to use the patient's full name and the MRN number. We want to avoid using the patient's room number to identify a patient, and to be honest, it's something that we do all the time. So please, in the inpatient unit, which we are, we're going to use 2 identifiers. You're going to read the patient's name and MRN off of the armband. So correct identification of patients also comes into play when we're talking about drawing labs. We would label the specimens at the bedside in order to avoid mislabeling the specimen. Additionally, you would want to remember that blood transfusions require a 2-person bedside verification, and again, you would be wanting to read the name and MRN off of the armband. Or of course, scan the armband when you're using Bridge. National Patient Safety Goal number 2 is to improve staff communication. So how do we do this? Well, one way would be by giving an organized and thorough SBAR report, and to be doing that report at the bedside, so bedside shift report. Another way would be timely reporting of critical tests and critical values. We use the critical value form in ad hoc, in Cerner ad hoc, to report any critical values that might be called by the lab or even called by radiology, micro, any critical values at all. Remember that you can use that form as soon as you recognize a critical value. You don't have to actually wait for the lab to call you. National Patient Safety Goal number 3 is to use medications safely. So here they're talking about labeling all medications and solutions. Although this labeling is actually pertaining to procedures mostly, they also want to make sure that we're labeling medication containers, including syringes, medicine cups, and anything that pertains to medications. So National Patient Safety Goal number 4 is reducing harm from anticoagulation therapy. This is a biggie. So using approved protocols for heparin and argatroban, mandatory use of drug library on the pump for infusions, VTE prophylaxis for all of our patients. That would include flotrons, mechanical, as well as pharmacological, making sure that they're started on anticoagulation if they're bedbound, and also assessing the risk every day for a VTE. Joint Commission surveyors would want to know that we are monitoring our patients adequately when they're on anticoagulation, and also that we are doing good education for these patients. They're going to want to see that we know what we document, and also that we can show them where we document both of these things. And it might be helpful for you to know that pharmacy will do extensive education and chart it when the patient is going home on any kind of anticoagulation. So National Patient Safety Goal number 5 is to maintain and communicate accurate patient medication information. This is basically talking about medication reconciliation. You would want to know that when a patient comes into the hospital, we do a section called Meds by History, which is recording the home medications or any medications the patient is currently on. Theoretically, the admitting RN would do the meds by history, and then the physician would do the admission med rec. Another med rec would be done anytime a patient is transferred, so transfer med rec, and then again, the medications need to be reconciled before the patient goes home. So this is a very important measure, and the spirit of the measure is to prevent us from overlooking very important medications that the patient may rely on. In particular, anticonvulsants, psych meds, and some blood pressure meds like beta blockers. We've all seen this happen when a patient is reliant on a psych med and we forget to restart it. This is a potentially lethal situation. A second component of this safety goal is to make sure that we are educating our patients on the medications that we're giving them throughout their stay, and in particular focusing on any side effects. So teaching them what the drug is for, but also what side effects they should be looking out for. The measure also wants us to make sure that we are printing out information in the correct language on discharge. So that's why we will always print out information for the patient if they're actually leaving from the ICU. Okay, National Patient Safety Goal number 6 is reducing harm specifically from clinical alarms. So for this goal, you'd want to be able to articulate that we have a no-pass zone in the SICU. The surveyors will be watching to make sure that actually nobody walks past a room when an alarm is sounding. The other thing you would want to remember is that we set our alarms to ring only when something is alarming. So you wouldn't want to set your alarms too tight. That would cause a lot of nuisance alarms. In most cases, using the default parameters set on the Philips monitors are appropriate for your patient. Goal 7 is to reduce the risk of healthcare-associated infections. Again, the surveyors will want to have the staff be able to speak about the measures we take to prevent infections, but also they will be observing. They'll be watching very, very carefully for hand hygiene. We have been warned by CMS that even one incidence of failure to perform hand hygiene as appropriate could result in an RFI being issued to the hospital. Of course, we need to know the WHO's 5 moments of hand hygiene, and what are they? Before touching a patient, after touching a patient, before a procedure, after any kind of body fluid exposure, and after touching the patient's surroundings. Very important as well that we can speak to what we do for preventing CAUTI, CLABSI, ventilator-associated events, MRSA, and C. diff. So here we'd want to be able to speak to all the bundles, the care bundles that we do to prevent these infections, and as well we'd like to be able to speak to our data. Generally, our rates in our units are very, very low despite the very high acuity in our patients, and that's just because you guys do such a great job. We'll have to go over each unit separately. Each unit has a display board for the data, and please find it, know where it is, and be able to speak to it. So goal 15, the organization identifies safety risks inherent in its patient population. So for us, the biggie would be identifying patients at risk for suicide. We screen all of our patients on admission for a risk of suicide. If we identify an at-risk patient, we implement a protocol which includes getting a one-to-one sitter immediately for the patient, removing any items from the room that the patient could use to harm themselves, that's called ligature risk, and getting a site consult. There's a red binder that is kept at the nursing station that will have the complete policy and all the forms that you need in it. Our surgical patients are another patient population that are considered vulnerable. It's hard to imagine, but wrong site and wrong side surgeries are still happening. For us in the ICU, we want to remember that before any procedure, we're going to do a universal timeout. And also, if there is laterality involved, you're going to make sure that the surgeon or the practitioner marks the site. And that would apply not really to like lines, but more like chest tubes or abdominal drains. So that's an overview of the National Patient Safety Goals. Now we're going to kind of talk about some random and hot topics. So we always need to know, where is the advance directive? So does the patient have an advance directive? If so, where is it? And if not, does the patient want an advance directive? Many people miss is that you first would look in the general consent. Here it'll say, do you have an advance directive? Yes or no. Do you want an advance directive? Yes or no. If it says there is an advance directive, then we need to know where to find it. If it says there is not an advance directive and we do not want an advance directive, then that's it, end of story. As far as finding the advance directive, the good news is there's going to be an actual tab that says advance directive in the chart now. So the advance directive will outline what the patient might want in case they are incapacitated or at end of life. It'll also name a surrogate they have named to make decisions for them in case they can't. If there is no advance directive, then if the patient is incapacitated, we need to find a proxy for that patient, and that's a function of social work.